So good evening to Lalit and to Adrian, to Katie. And I think we have quite a lot of alumni who are joining us today. My name is Julie Nazarali, and because we're online, I'm based in Brussels and in Belgium. And Lalit, I think you're in Leeds in your home office. And Adrian is sitting in a car on his way somewhere, and I think you're also in Leeds. So it's my pleasure to welcome you both, gentlemen, and it's my pleasure to welcome the alumni who are joining us and alumni's friends this evening. So we have an interesting journey of about an hour into Adrian and Lalit's journey of entrepreneurship, bringing together a marriage of health and technology. We are all Gemba, and I'm Gemba 14. Lalit, you are Gemba 16.
16, yep.
And Adrian, you are Gemba 16 also.
Yes.
I don't know if Charlie is with us, but Charlie was my Gemba godmother, because she really helped me to think about whether I wanted to go to INSEAD, and I ended up there. And we have a very nice story together, which will be for another time. I don't know if she's here, but welcome if you are, Charlie, and thank you for asking me to join you this evening. So just a few housekeeping. We will be going for an hour. I will introduce shortly Lalit and Adrian. And what we'll do then is we have a presentation of about 30 minutes. We can't see the participants, but maybe at some point we will be able to invite you on if you'd like to be participating in the live chat. Otherwise, as we go along, we have features in the Zoom which allow you to pose questions. So please pose any questions you have in the chat. I think there's a chat and a Q&A button at the bottom of your screens. And so I think without any ado, let's start. So Lalit, you are you said yesterday from Mumbai. We met at INSEAD, and you'll give us a little bit of your background. And also, Adrian, you're a doctor. You've been working for the NHS as a consultant and you mentioned in obstetrics and gynecology, and you'll explain hopefully a little bit about how you got into the med tech industry, and also this entrepreneurial journey. What is iTecho Health, and how has COVID accelerated your journey? Voila.
Thank you very much. So yeah, it's a pleasure to join everybody this evening. I'm actually on my way to a 70th birthday party, social distanced in Oxfordshire, so apologies that I'm in the car, but hopefully the technology works just as well. So just to introduce myself, so I'm Yorkshire born and bred, and after many years away, moved back a few years ago and had a great lockdown actually, because I live on a river, able to go canoeing, cycling, and live on the edge of the Yorkshire Dales National Park. But I trained as a medical doctor initially in Newcastle, worked in Edinburgh, back in Yorkshire, had a year as a registrar in Brisbane and in Toowoomba in the sort of middle of Australia in Queensland, and then settled down really for the rest of my public sector career in the southeast, and finished training in obstetrics and gynecology, and then moved to public health and did training in public health mainly in London, and was settled in Brighton and did the commute from Brighton to London for I think 15 years. And can we get the next slide? And worked at a sort of senior policy level in London, and also in commissioning services, specialised in the redesign of services, including major projects around stroke, cardiovascular disease and cancer in London. And my last post was at an executive level with Public Health England, and I was leading on all the national screening programmes for London. I've been interested in digital health, however, for about 15 years, initially when I was working at the Department of Health, and within the 10 years as a consultant in public health in London, did many projects which included digital health. The biggest project I then did was an EU-funded project, and I was the lead for innovation for a project funded by the EU Horizon 2020 programme for about 5.4 million euros. Next slide, please. Which was to use a platform for the remote monitoring of patients with stable HIV across 5 sites in the EU and around sort of 12 to 13,000 patients in total. So that really sort of solidified my interest in digital health, and overlapped with me deciding to leave the public sector and Public Health England and go to INSEAD to do my Gemba. So I hand over to Lalit.
Thank you, Adrian. My name is Lalit Suryavanshi. I'm originally from Mumbai in India. And so when we're talking about my journey, I thought I'll put the first picture available of me. So that's where it started. I did my engineering in India, started a IT career in India, worked with Air Canada, Equitable Insurance, and then moved to UK 17 years ago. I predominantly worked in retail industry and logistics business. And then I went and joined my executive MBA in 2015 with Adrian. And that's where we kind of started talking about what to do next. And there came the Charlie's boot camp, and we did our boot camp together. And I came first. And of course, Adrian came second. So then we decided, okay, so might as well join forces and do something together. And then because we both lived in Leeds, it kind of made sense for us to base our company in Leeds, and we co-founded ITECO Health in 2 years ago, in 2.5 years ago in Leeds. So that's our journey from NCAD to starting ITECO Health. In the next few slides, we'll take you through where we are and what we do. Adrian, please.
So if I sort of take the story again, so once upon a time before coronavirus COVID-19, so we formed the company in 2018, and in May last year, we moved into Nexus, which is a really exciting innovation hub at the University of Leeds, which is more than just a building. We have a collaboration manager who introduces us to researchers and provides various opportunities for us to benefit from internships across the university. We were also successful in an application to the Yorkshire and Humber Academic Health Science Network, to their Digital Health Accelerator programme, and things were sort of ticking along. Next slide. And we initially focused our platform, which is called Acellus, on the management of long-term conditions, building on that work that I'd initially done in HIV medicine. So in terms of long-term conditions, it's a huge market. So 80 million people have a chronic disease or a long-term condition in the EU/UK. And that has an annual cost currently of 700 billion euros, and that's going up year on year. And prior to COVID, the number of outpatient appointments in England actually doubled over a 10-year period. So nearly 100 million appointments in England. And by far the majority of these were for follow-up appointments for long-term conditions. However, healthcare budgets can't really keep pace with this growth. So therefore it was necessary to find more efficient and productive and economic models. So our focus is on 3, I guess, sort of pain points from patients, commissioners, and from hospitals. So for patients, they're used to having frequent hospital visits. Many are sort of routine checkups that really need not be face-to-face. And for commissioners, there's an increasing proportion of the budget spent on long-term conditions, and the costs are rising much faster than the growth in the budgets. And for the hospitals, outpatients are really running out of capacity, and there's increasing demand from chronic conditions. And there's insufficient time for doctors to spend on more complex patients because they're seeing these patients for routine follow-up. So our concept is to reduce the number of hospital appointments, keep some of them, the necessary ones, and to replace them, the others, with digital health monitoring with our SLS platform, which links the patient and the clinician. It's fully integrated through APIs with existing hospital IT systems and securely connects the patients and their confidential clinical data with their existing clinical team. So we're not inventing another loop. And then there's also AI integrated into the platform. So I'm just going to show you a brief sort of film that, or animation that gives an overview of the technology. Oh, sorry, we've jumped ahead. So we have benefits from our technology across those three pain points. So for patients, it's more convenient. We can eliminate duplicate tests for patients that have more than one long-term condition, promote the normalization of lives, and using AI and other fail-safes improve the quality of care. For the commissioners, we've got the same or better quality. We're reducing the cost significantly of face-to-face appointments. If we just reduced follow-ups in the northeast of England, for example, by 5%, that would release £86 million. And in the hospitals, we're freeing up capacity so clinicians can concentrate on more complex patients, link between specialties, and also incorporate management algorithms using AI. So pre-coronavirus, we're concentrating on three projects, one in haematology around a pre-malignant long-term condition called monoclonal gammopathy of unknown significance, which rolls off the tongue, or MGUS, which many people haven't heard of, but actually affects 5% of over 50-year-olds. So it's about 500,000 people in the UK. And once it's been detected or diagnosed, it needs lifelong monitoring because 20% will actually progress to multiple myeloma, which is bone marrow cancer. And patients need to be monitored every 6 months. And that's a project with King's College and with Sheffield. A project in fertility using AI to tailor specific lifestyle change, particularly around exercise, to improve IVF success rates, and that's with Leeds University and clinic. And then in advanced prostate cancer, we applied to the National Institute for Health Research Invention for Innovation programme with the University of Sheffield, and that was successful. And we've got another film clip about that project.
I was first diagnosed with prostate cancer around about the end of May, beginning of June this year, here at Western Park, under Professor Brown. The outpatients department can be very busy. Not like I've said, I waited 3.5 to 4 hours in the outpatients. Well, I've sat in that car, line of traffic out there many times.
I'm Dr. Carmel Pizarro. I'm a medical oncologist. I work in Sheffield at Western Park Hospital, and I do not think it is acceptable to ask people to be waiting hours to be seen, especially when you are unwell. There are challenges in terms of consultant numbers, there are challenges in terms of allied staff, there are challenges in terms of the capacity we can actually have in the hospital, which means that there are a limited number of patient review spots available. The reality is that we cannot keep the old system of monitoring with additional numbers and additional complexity and expect our systems to cope.
Iteco Health has developed the slowest digital health platform. Using principles of co-design with clinicians and patients, we support care pathway redesign and can integrate slowest with existing local hospital IT system. This allows the number of face-to-face appointments to be dramatically reduced, creating savings and capacity for commissioners and hospitals and a more convenient service for patients. Patients enter information on symptoms and side effects and receive blood and other test results together with advice from their clinical team direct to their smartphone.
I believe that remote monitoring allows more timely communication between clinicians and patients and their families.
I don't think it'd be a good way of bringing care together, that, because you use the word fragmented. It'd be really useful to have it from the hospital, coming from your own, like in my case, Professor Brown. Also, it'd be useful for your GP. The only thing about not coming to the hospital as much would be that I've got a couple of grandkids below school age, and it would maximise the time that I could spend with them.
This application to iFry Connect tests our technology in the management of advanced prostate cancer. This groundbreaking feasibility project will involve detailed work with patients and clinicians to study the impact on empowerment and engagement of patients and economic modelling through 7 interlinked work packages. We hope this will pave the way for a larger, multi-centred study underpinning scale-up across the NHS.
Thank you. A slight glitch in the technology. So I will explain you quickly the platform we have. You must have you saw a lot of different disease areas we covered. What we did is we developed the platform called SLS, which is our platform. Working with NHS technology, you have to have data in the UK and it needs to be secure. So we have developed a platform on cloud, which is secure, safe. We use 2-factor authentication. The data is all encrypted, GDPR compliant, and it's in the UK. So that is a key to get confidence for the NHS hospitals. The way we work is all your data in your hands safely, and the hospital give you all the consent when you have the data in the UK. Adrian?
Can you hear me still? Yeah.
Yeah, we can hear you, Adrian.
Yeah, sorry. So that was our sort of work before coronavirus, and then along came the virus, and that's really been a game changer for digital health. And just to quote one of the senior executives at NHSx, which is the sort of digital arm of the NHS, he said he'd been working in digital health for 14 years, and more had happened in 3 months than the rest of the 14 years put together. So really things have moved apace. So during that time, we've developed the platform from those initial 3 conditions to actually mapped out 24 conditions in total. That's partly was aided by a team of medical students from the University of Leeds who worked with us, and this enthusiasm of clinicians from King's College, from Sheffield and from Leeds, and from patient groups. And we actually managed to engage 5 additional patient groups and charities in different conditions to collaborate with us to get the patient views on digital health on these new conditions. We also rapidly registered as a medical device with MHRA, the Medicines and Health Regulatory Authority, and registered with NICE, the National Institute for Health and Clinical Excellence. We were asked to develop our platform for the NHS Nightingale COVID hospital in Harrogate, which was due to cover Yorkshire and Humber. That didn't open, but I'll show you some more slides of that in a second. And we've also spent a lot of time prioritising registration with 3 procurement frameworks, which then allows us to sell to the NHS and avoid large tender processes. And we've also differentiated the product, so we want the company to be able to be a one-stop shop for digital health for hospitals and for commissioners. We don't want to be, we actually ban the use of the word app in the company. So it's a platform which is differentiated to meet all the digital health needs of NHS customers, and I'll tell you a bit more about that in a second. So in terms of the NHS Nightingale, this was built and is there. They commandeered the Harrogate Convention Centre, which you may have been to for conferences. It was used for hosting the Eurovision a few years back when we last won, or the time before. And quickly, as the NHS Nightingale in London, it was transformed into a hospital with intensive care capacity. And that was finished in April, however, didn't actually open or hasn't been required yet. It's still there and it's still ready to be opened. And we were asked by the Yorkshire and Humber Academic Health Science Network to develop our platform so that we could monitor patients who were on ventilators and follow logistically patients arriving at NHS Nightingale and leaving NHS Nightingale. Here's some of the screens that we developed for our platform. So that's the view of patients, that's the sort of symptom tracker. That's another view in terms of the ventilated patients and the blood pressure readings. So what we also have done, I said, around sort of developing our offer so we can be a go-to company for digital health. So Lalit designed the architecture of the core platform so that it could easily be amended for new diseases and new uses. So we've differentiated to have a Salus Lite version, which doesn't require integration with the NHS systems. Salus Vital Signs, which we can link with vital signs monitorers, including wearables, so that we can then have a package for the NHS for patients' vital signs that are monitored at home, and that includes patients that are post coronavirus. Morphing the platform so that it's friendly for pediatrics, for Salus Kids and Salus Young People. And then a really interesting side project is Salus Real, and that's using our platform with drug companies to collect data on clinical trials and real-world implementation. So many drugs are sort of approved by NICE, but only for a 2 to 5 year period, and that's called managed access. And during that time, drug companies, big pharma, have to collect data on the benefits and the costs, and it's then revisited in terms of their approval. And using our platform and the symptom tracker and the observation checker on the patient user application, and then also from the clinician's platform, we'll be able to provide exactly that data that they require. And the quality of data at the moment is really, really poor. So that's a big market opportunity. Next slide. So within the last year, we've received around 250,000 in funding through grants from NIHR, from the Medical Research Council, the University of Leeds, Department of International Trade, and Grow Medtech, which is a Yorkshire sort of medtech ecosystems supporter. We're also at the final stage of a large grant for 1.96 million across hemato-oncology, or cancers, blood cancers, and we've got the presentation and panel day at the end of November. As I touched on, we've completed procurement exercise. We're part of an intention to tender at the moment with NHSx, and also G-Cloud, which is the Crown Commissioning Service procurement framework. And that's really taught us a lot around due diligence and interoperability with NHS systems. We've managed to grow our team. So Lalit and I are full-time. We have a full-time R&D officer, and then we've got 5 other part-time posts who have come to us through that collaboration with the University of Leeds, and increase the number of academic and NHS partners that we've been working with. This is just some of the key milestones over the next year or so. So we've launched our products now, that's gone live. We're working on the artificial intelligence integration. I mentioned about differentiation of the product. We hear from the NHSx procurement, ITT, any day now, and then we're launching next month our initial investment round. So far we've managed through grant funding, and then hopefully from next year onwards we'll be commissioned by multiple NHS trusts, and then look at international expansion, hoping for a revenue of around 3 to 5 million at year 5. And our exit strategy is to continue to build the company through R&D and grant funding, but also through investment over the next 5 years, to then hopefully lead to a trade buyer or a private equity management buyer. So that's really our story. So we wanted to open it up for discussion.
Julie,
Excellent. Yeah, sorry. Excellent. Thank you so much. Very, very interesting. Is it possible for us to have the 3 of us on the screen? Great, great. So I did ask you this yesterday, but how is this entrepreneurial journey for both of you? What have you learned? Because you met together in 2015 and it's 2020 now, and you've got a 5-year plan. What's it been like, if I may ask? And just before you answer that, both of you, I just want to invite the participants that they can please give their questions in the chat or the Q&A box as they wish. So maybe Lalit, you can start, because you're not in the medical field.
No, so I'm not, and that was the point I wanted to make. So for me, it was like really steep learning curve, understanding what MGUS is in the beginning. And then when you're in the business school, it's all about, okay, the traction means you're going to start selling at your 20 customers, you start selling them and you get the money. And here it's quite a long-term thinking. And we mentioned a few times about NHS procurement framework and projects, and a lot of people don't understand that. Why are they doing projects? The whole idea is that in NHS, you can't just go out and sell. And for me, that was a big thing. It is not, you're not selling a chocolate or something, a commodity product. You have to first prove that it is a care pathway which patients can safely use. The data is securely stored. So all those things matter the most. And once that is done, then you can get into the procurement framework. And once you're in the procurement framework, you can sell. And that cycle is slightly longer. But once that is there, the deal sizes or each tender size is quite big. And for me, that was coming from a retail background where you can sell chocolates and earn money really quickly, to understanding the slow cycle. For me particularly it took me a long time to understand. From technology
to Adrian, but how did you find managing your emotions around that? Was that quite hard?
Sorry, managing the emotions around
this slow, that it's not just about selling a chocolate, as
Sure.
Lalit said, that it's a longer. So you have to have a lot of resilience.
Yeah, I mean, I guess my sort of journey's different because I've sort of gone from the public sector and I've also worked in the NGO sector. So this is my sort of real first time in the commercial sector. And so that's different. I think the other thing which is probably common with all entrepreneurs is, you know, having to spin many different plates, wear all the different hats, be the director of finance, be the director of marketing. Actually, that's a lie. We have a very good third member of the group who is our creative director. So he does that, called Matt. But really sort of try to cover all the different bases, which is very different to working in the public sector in a massive organisation where you've got huge teams which are very specialised. I think to sort of reiterate from what Lalit has said, and I think I wasn't naive about this in terms of the slow progress with the NHS and the need to sort of swim through that sort of bureaucratic soup that's there. And I think that's COVID's really helped to sort of, I guess, give us an engine at the back to go through that soup, and hopefully that sort of momentum will be maintained and things won't go back to normal.
We do have a question which is about the internationalization of what you're doing. But before I ask that question, I'd like to probe a little bit more into the UK health market, because each market for health is national. And you might want to just give us a little bit more of the experience, because you said it's the NHS market, and there's also a private sector market, there's a pharma market, is quite cumbersome, it's quite heavy. And we were discussing yesterday when we were just sort of touching base that many years ago when you were working as a doctor and I was a partner in a law firm, I was in a partner that had a very strong health basis, and we worked with the NHS. So we did a lot of procurement. And it seemed to me, because a lot of the tenders, you talked about tenders, the ITT, etc., and the process is very form-based. There's a process of competition, you know, for work, supplies, and services. Where do you fit in there, so that we understand? And do you work in consortia and partners? Let's understand the UK market, and then I'll pose the question that's been asked about the international market. And again, please, participants, do ask your questions in the boxes. We're happy to answer them.
Yeah, so first of all, within the UK market, within the NHS, it's very different across the nations. So my familiarity is mainly with England. Scotland's very different. Scotland's maintained, or should we say, it didn't go to that purchaser-provider split, which the Thatcher government brought in quite a long time ago now. So in Scotland, it works much more simply that money is given from the Scottish government to health boards, and then the health boards do the sort of planning or the commissioning and the service provision. Whereas within England, that's split in terms of you have commissioning or purchasing organisations, and then you have provider organisations such as hospitals or NHS Foundation trusts. That adds the sort of layer of complexity in terms of who actually is the customer. And so we need to build relationships with clinicians, with managers within the hospital. But in terms of sort of realising savings in this sort of model of reducing face-to-face appointments, actually those savings are more with the commissioners. So it needs to be quite a sort of complex relationship around navigating that. And I guess I was at the advantage that I sort of lived and breathed that from the other side for many years, although it is sort of morphing a little bit, but still in contact with that. But it is complicated, and I think there's still quite a lot of, on the one hand, the NHS is top down, so it's sort of policy driven. So this NHSx ITT, for example, is national. But on the other hand, individual hospitals and commissioning groups, such as CCGs, are individual legal entities in their own right and have their own little fiefdoms, and we can't, for example, say, okay, we've passed the information governance and the data security in Sheffield, therefore it's fine in King's College. So you have to, obviously it's quicker to navigate through that if you've already got the track record, but And that's one of the reasons why I think digitalisation has been really slow in the health service. And I think organisations like NHS England, NHSx and NHS Digital are there. They've produced the right policies, but it's trying to get them implemented on the ground. In terms of, are we going to move on to the international? Did you want
yes, but did you want to finish what you were going to say, or I'm happy to
sorry, just in terms of the procurement, I think the other thing to say is, unlike sort of selling, I guess, sort of high volume products at a sort of low price when you can potentially get revenue quite quickly, this is a slow burn, because a potential contract value is going to be a minimum of £100,000, which is above that EU threshold for tenders. And that's why it's very important to get on the procurement frameworks, because in effect you then bypass, or you do in bulk that tender process,
right.
So that then individual organisations can draw down, as they call it, from these procurement frameworks. So that's a really important thing that we're hopefully have got through in the next few
Which
years.
then requires you to do a lot of handshaking and meeting people and selling yourselves.
And lots of due diligence. But once you're through that,
yeah,
it's then more around relationship management, traditional sales and marketing, to say, look, we've got this product, we're on the procurement framework, you can buy from us. And this is our USP compared to the competitors.
Right. We'll come to competitors in a minute, but let me take Barbara Domain Heyman's question. She said, how easy would it be to adapt your approach to non-UK healthcare systems? Because here we're talking about a lot of barriers. And have you looked at the US and their insurance payer system?
So I think what all health systems have in common, and we might sort of look abroad and sort of think, the NHS struggles, but it's universal that this increase in demand due to an aging population affects all developed countries, whatever the healthcare system. Even now in the Middle East, where they for many years seem to have a lot of money to throw at healthcare, even they're now looking for ways to sort of get better value. So I think that's universal. I think what's different is who the actual customers are, who you're actually selling to, and then obviously the sort of scale. What's interesting from the technology side is it's pretty similar, and having been involved in that EU project, we built the interoperability of the connections across those 5 sites. Interestingly, the Spanish system was the most technologically advanced, and the Croatian system, it was literally an Excel spreadsheet of names of patients that had HIV. But we were able to show that we could get the platform to work across the different sort of levels of technological development. So we're confident that we can do that in any healthcare setting. It's really, who are the customers, who do we market to, and so on. In relation to the US, yes, we're very interested in that market for obvious reasons. The benefits in terms of the realization of savings would be more with the insurers or through their sort of managed care system, rather than with the individual hospitals. We've just got through a Barclays Eagle lab, found out yesterday they have a program for trying to get medtech companies into Silicon Valley, so we were successful with that, so that starts in a couple of weeks. And then we've also done some work with KPMG and their US healthcare team, so we're definitely looking at that market and the opportunities.
Is it true that Estonia is very advanced in medtech if you compare it to the rest of the EU?
Yes, I think not just medtech, I think across technology generally, that there's a large number of programmers there, and I think it's so we have a programming and development team in India for possibly obvious reasons that Lalit has connections there. And obviously that's a lot cheaper than developing and programming in the UK. And I think that's why the Estonians sort of got in that market, but they had the added benefit that they're part of the EU, which I think has helped them with information governance and sort of data security. So yeah, I think it's big across technology, but potentially especially in medtech. Yeah.
Lalit, maybe you would like to tell us a little bit about how you put your team together. You've just talked about it, Adrian, in India.
Yeah, so when we started initially the talks about developing a platform, and I was very keen that yes, we're working on one long-term condition, and I think I gave you this example yesterday as well. In my head, it was my mother who lives in Mumbai. She has high blood pressure, asthma, and diabetes, all three long-term conditions, and she has to see 3 different doctors, and she pays for it, but she wastes like 3-4 hours every time she goes and sees a doctor, and most of the time it's the same medication. So I was trying to understand how can I link this to what Adrian's trying to achieve with HIV, and then the only concept around that was build a platform. Now we can sink millions into building a platform first, and then start finding out solutions. But what we did is we kind of organically growing is because of the experience we have now. The idea was that don't try to do the whole thing at once, build it one at a time, with the full view that once it is all done in say 2-3 years time, we can just plug and play any disease into it. So that's how we did. We do have, as I said, we chosen in Mumbai as an option purely because my links there. So it's certainly cheaper, but then because I come from the same background in terms of technology, I can easily keep an eye on it. And it's important that you just don't find a outsourced service provider which is cheap. You have to know them really well, deeply, and you have to control it. So it takes a lot of hand-holding, and because they don't understand the market here in terms of the functionality and how the business works here. But the technical skills are top-notch. You have to just bridge that, and so it's constantly communicating with them is important. We would have loved to have a team here, but I don't know if you know it, but Leeds now is the second most expensive place to hire basically programmers in the UK. Leeds has a very big technology center now, so it just becomes very difficult. So that was the reason.
So that's a great explanation. You did talk in the presentation, and my phone was going, sorry about that, but that was probably my mother. So I'm thinking about my mother, and you talked about your mother, but you talked about it being very helpful for a certain age group. And if I think about my mother, you know, how will my mother or Lalit's mother deal with the technology? Because there's a bit of an exclusion there. What do you say about that?
So I think that's been interesting, and that I mentioned about the work we do with patient groups and patient-focused charities, and they've all sort of reported that that people that were sort of technophobes have during lockdown sort of become less so, and they, you know, now having Zoom meetings with their grandchildren and that sort of thing. So I think that has sort of moved people along that journey. In terms of, a lot of people talk about age, and I think age is just one of the sort of inequality strands that we're interested in. And in terms of our USP, the sort of 2 areas which we're concentrating. One is that we're built from science, so in terms of being really strong on R&D, and we've got collaborations with 5 universities now. But the other one hasn't sort of come to the sort of public policy forefront yet, but I'm sure it will. And I think that's around leaving nobody behind and making sure that digital health is for all. So that's not just elderly, it's looking at patients in sort of socially deprived groups that might not have smartphones and so on, and actually sort of developing our products and our projects and our collaborations so that they don't disadvantage people. And obviously coming from a public health background, that's sort of personally quite important to us, and we've embarked on some work just in the last couple of months to have a strategy for that, which we see actually has commercial value, because I think that's going to become important for the NHS.
Thank you. We've just got a question here from Richard Washington. He's asked, why did you choose to start with these conditions versus bigger conditions like diabetes and asthma?
So diabetes pretty much has sort of been done, if that's good English, and even to the point that one of the funding grants that we applied for, they said we're not interested in diabetes because there'd already been a lot of work in diabetes. So it's partly to carve out our own niche. Hadn't been much work at all, and still hasn't in cancer, because it was sort of put in the too difficult box, although actually I don't think that is the case. And also there wasn't anything in haematology. In asthma, we recently have just been doing a project in childhood asthma, so we have started work on that.
But the idea was, and this is a key differentiation here. We are not creating a product and trying to sell it in the marketplace. We are working very closely with King's College for hematology. For advanced prostate cancer, we are working very closely with Sheffield University. So that gives us a solid foundation when we go outside of UK or even in the UK. We didn't mention about Arab Health. We were in Dubai beginning of this year, before COVID, and we got a lot of positive vibes from the people in the Gulf, because when it comes from NHS approved tag, people want to work with you. And as Adrian mentioned, if you would have just as a first project chosen diabetes, then you would have been lost into like one of the 100 companies who are doing it, and it's very difficult to then get into that. This one, like MGUS in hematology or advanced prostate cancer, the person who you saw in the video is a real patient, 72-year-old person who has 16 appointments a year, and every appointment is like 4 hours. He's terminally ill. If we save 8 of his appointments, yes, there is a cost saving for the NHS, but that guy, in terms of cost of living, in terms of his for his health and well-being is great. He also mentions in the video that he'll spend that time with his grandkids, and that's great for the patients as well as to the NHS. And we just want to essentially find out those kind of niche areas first. And the platform supports, as I said, once we get into a procurement framework, and once we get into any hospital, we can vertically or horizontally go into any disease area. It's very easy for us to just plug in the same platform for diabetes or asthma. But then to gain an entry into the hospital, we wanted something where it's out.
So you'd have a USP. So we have one last question, which I'll take again from Barbara. And she asks about your business model. So I'm just going to, this has gone very quickly. It's now in your country, 16:54. So her question is, if I'm allowed another question, yes you are, Barbara, could you say a bit more about your business model? How do you charge for your services? Is it per patient? Does it vary if they have multiple conditions? Or is it on a subscription per hospital basis? Thank you, Barbara.
Thank you. So it's sort of D, all of the above in a way. So we've got a flexible pricing plan. Principally, it's around subscription per cohort size, which is deliberate in that then leaves the onus on the hospital to actually recruit patients to the system. So if, for example, we said it was going to be £50 per patient per year, then we as a company, we're not actually marketing directly to patients. Or we can, but that's difficult through GDPR and so on. So if we say, okay, you have a cohort of 700 patients that have cancer, and this is going to be the cost per patient within that cohort. So that's a subscription, but it's a subscription by cohort size. I said that we're keen that because the NHS is really big numbers, they don't want to have an app for this, a different app for this, a different company that's doing this, whatever. So we want to have that breadth that we can actually offer across their digital health needs. So that's our ambition. And obviously the sort of pricing, the bigger the service, the bigger the better the sort of value for the hospital. We also, through our collaborations with the University of Leeds, also in York, are offering wraparound consultancy, so to do health economics and care pathway redesign and evaluation. So rather than just saying, here's the product, take it away, we help them to actually evaluate, do the patients like it, what's the impact on empowering patients, and then obviously the economic impact through our health economists. So it's more than just, it's definitely more than just an app, and it's more than just a platform.
We have just a few minutes left, and what I would like to ask is, we had that slide with the steps going up, and where I think, if I recall, that you would be earning this amount of revenue. So that sort of links in with the question we've just had from Barbara. But what you're looking for, you will have an investment round. Tell us a little bit about that, and how anyone who's been watching this can be in contact with you. And do you have an investment sort of pack that people can sort of get from you? How do we go forward?
So absolutely. So we have the investment pack. We were about to do an investment round just before lockdown, sort of friends and family plus angels. And we sort of paused that to concentrate on the development and sort of take the opportunities of procurement frameworks and moving to more conditions. But we're ready to do that now. And Lalit, do you want to give a bit more information?
Yeah, so if you can get in touch with us, either we'll share our contact details anyway. We can share that, and we for the first round we're looking to raise £1 million. Again, as just to start the investment rounds. That's the idea. Because I think we are in a position now to start recruiting our marketing and sales team. Because once we are into procurement things, we can start doing that. And we already have a lot of hospitals we're talking to anyway. And so this just gives us a solid base to start.
And the other thing that funding would be spent on is, we've done a lot of the mapping, but we need to have funds to actually do that programming across those 24 diseases plus other diseases. So that's what the main two things that the funding requirements are for.
Excellent. Lalit, did you want to say something else? You looked like you were about to jump in.
I'll just, we deliberately didn't raise funds for nearly 2.5 years. Mm-hmm. The whole idea was to essentially build something and create the value, rather than just going in the market. And as I was saying to you yesterday, because it's slightly longer process compared to the other startups we see. That was a decision we both took, and that's why. And grant funding actually helped us. Sorry, as you rightly said. So we nearly 300k grants, and plus we're hoping to get this another 1.96. So.
Excellent. So boot camps do work. Charlie's boot camp does work in Fontainebleau to put people together. So it's a very nice story. And if I give you your last word, what would each of you say about your journey so far?
Well, go on, you can go first.
It's exciting. 5 years ago, I would have thought I'll not do anything with medtech. I want to do distribution business, but it's exciting and great time. So thanks to NCEAD, actually. Is it to do with NCEAD? You wouldn't have done it? It's purely because of NCEAD I'm here with Adrian. And as you don't know, but I'm also a VP of Technology for NCEAD's UK Alumni Association. So. I had seen that. That's right.
I mean, my reflection is it's nerve-wracking.
You look calm though.
Lots of plates to spin, but I think what's been incredible is the amount of interest across stakeholders, and that COVID-19 sort of really galvanized and catalyzed that interest. And you know, obviously we didn't have time to go into that in great detail, but we've built a huge number of collaborations So we've got our own ITECA health team, but then we've got a sort of wider team, probably about 40 people who we can go to and get support effectively sort of free of charge. I guess on the promise that the technology will be implemented and support them. So I think that's incredibly exciting. I think for us, the next step around investments also hopefully going to be really rewarding, so that we can then grow the team and actually deliver the products across the NHS.
Excellent. So gentlemen, I think we are 2 minutes over time, but I think we started a little bit late, 3 minutes late. So I wish you the best of luck. It's really nice that Gemba's stories actually work, and that Lalit, when we met during the electives in July so many years ago, that wow, it's sort of when I saw on social media that you guys had formed something together, it was quite exciting. And so I really wish you the very, very best, because it shows how technology can help us, especially in these times of pandemics, which are very unfortunate, and these difficult times. So thank you very much. Thank you for allowing me to be your moderator today. And I wish you all the very best. Katie, I don't know how you want to close the meeting. And I thank very much the participants who asked questions and who listened. Thank you very, very much for your time today.
Thanks, Julian. Thanks, Katie, and Charlie as well.
Wonderful. Thank you, guys.
Thank
Take
you,
care.
Julie. Thank you,
And
Madhu.
hopefully we'll see you in person soon.
Yeah, and please, everybody, do get in touch with us. We welcome as much support and further discussion as possible. That'd be great. Thank you very much.
Excellent.
Take
I
care.
hope you enjoy the 70th birthday party.
Yes, no, I think it'll be a fair bit of fizz, so that should be good. Obviously,
Excellent.
finish driving.
Good evening, everybody.
Take care. Bye-bye.
Bye-bye.
Bye-bye.